Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z.
and John. Well, good morning, Zara. It's really nice to see you back in Vancouver again from your trip overseas.
Thanks.
I'm sure the audience would love to hear about your volunteering at one of the major hospitals in Kenya. So can you fill us in about what you've been doing over there for the last 3 months?
3 months. Sure thing. John, great to see you again. And lovely to be here, even though it's really cold. I miss the warmth of Kenya very much. The sunshine was wonderful. Yeah, I spent the last 3 months volunteering at the Aga Khan University Hospital Cancer Center and trying to get more clinical trials to the actual cancer center for sub-Saharan Africa in Kenya. Because unfortunately, Black African patients are not represented in global clinical trials, specifically in oncology. And it was a wonderful experience, great people that I worked with, lots of work still to do. And, when you try to understand the infrastructure and the healthcare system in Kenya, very different than what we have here in Canada. And of course, what we have in the United States, 80% of patients only have access to public. And it's challenging, but you know what? Very doable. And it was an amazing experience. So we may need to have another episode just on that alone. But I'm glad to be here this morning. So thanks, John.
That's good. I'm glad that you're here. And we're also very happy to have Professor Philip, MD and PhD, Professor of Oncology from Henry Ford Cancer Institute and Wayne State University. Professor Philip's specialty is GI neuroendocrine medical oncology. And we're very happy to have him talking about pancreatic cancer. Pancreatic cancer is the 7th largest cancer globally. And there's 511,000 patients diagnosed with pancreatic cancer in a year, newly diagnosed patients. But what's more important is 465,000 of those patients die per year. The 5-year survival of pancreatic cancer is around about 4%. So we're very privileged to have Professor Philip here talking about this very insidious, deadly disease, about signs, symptoms, the treatment, and the new technology that's coming our way. So, Professor Philip, would you please introduce yourself to our audience?
Yeah, thank you.
Well, thank you very much, John, for the invitation. We go back many decades. And also I'm privileged to be with Zahra, who has done a great job in helping out, especially areas of the world that do not have oncology services as we have here in the way. And I have to say that oncology services is not only giving drugs, it's really a full package of supporting patients, diagnostics, symptom management, and all that comes with it.
Absolutely.
And I hope you agree with me on that. Yeah.
No, 100%.
Yeah.
Cancer education and wellness is a big component.
Yeah, survivorship and early diagnosis, prevention. Pancreatic cancer has been the disease that I have focused on both in the clinic and also in terms of the research I have done and also research that I help others to develop. The 5-year survival rate actually now is officially over 10%. When I first started 3 decades ago, it was the 4% you mentioned. And at the time, there was barely one drug that we can use in the patients who cannot get surgery, which, by the way, 20% of the patients only end up with surgical resection. In other words, a shot at cure. 80% of the patients present with what we call advanced disease. Could be wildly metastatic or it could be locally advanced, meaning that it's there in the pancreas, but the surgeon cannot touch it because it's surrounding arteries. It's hugging an artery that cannot be sacrificed by cutting through it.
So can I ask a question right at the outset? Like, why is that the case? Why is it that 80% of patients present so late? Is it that there's a lack of screening techniques, or what are some other issues or components that you can mention?
That's exactly right. Unlike breast cancer, unlike colon cancer, prostate cancer, and nowadays lung cancer, there is no established screening procedure for this disease. That is to say, when the patients go to see their primary care doctors, the primary care doctor has really, in someone who has no symptoms, no reason to do a scan of the abdomen, because that's the best way you can detect it early in many cases. Now, less than 10% or even 5 or close to 5% of the patients, they may have some red flags that will alert the primary care provider to do a test on the patient, a screening test or surveillance test. But these are only a minority of the patients. These are people who have family history of pancreatic cancer or other related cancers. These are people who carry a gene that is really predisposing them to develop cancers like pancreatic cancer, but then they have to know that they carry the gene. A lot of people in the community carry the gene, but they do not know about it. So these are the patients who may be candidates. I wouldn't call them patients. I would call them, these are the individuals in the community who may be candidates for a primary care doctor to think about doing a scan on, say, annual basis, or even other tests that can be done to look for pancreatic cancer. But pancreatic cancer will not be the only thing that people are predisposed to. So it becomes a bit complicated. However, there's also room for early diagnosis in patients who have symptoms, because that means that patients may come to the doctor earlier than they have developed or before they develop metastatic disease. And as you know, patients can develop spread to places like their liver, in which case they definitely are not as candidate for surgery. So there are symptoms that the patients have to be aware of. Again, I'm not saying patients because they're not patients yet,
Right.
because not every symptom really means cancer. I don't want to really frighten people saying if you have a bit of abdominal discomfort, you have cancer. But there are symptoms that, again, talking about the abdominal pain, if abdominal pain is hardly explained in you, it's not like it's there and it's gone the next day or 2 days later. It continues to be there. It comes and goes, but still there, especially if it shoots to the back. If there's some weight loss with it, those are things, for example, people have to jump on in terms of going to see their primary care provider. One of the early signs of cancer, which is localized, is actually the eyes turning yellow. We call it jaundice, which also with it would be dark urine. So that's another situation where we might be able to catch the disease at an earlier stage. So seeing the doctor immediately when someone develops that. But again, I have to be very careful because the symptoms can be, we call them non-specific, means that we don't want to really scare everyone with anything they get from that perspective. Certainly, patients who come from families of higher risk, there is a cluster of cancers in the family. Those are maybe should be having more vigilance when it comes to such symptoms. And again, I go back to the small proportion of the patients, very small, who carry a gene or they know they carry the gene or potentially they are carriers of the gene. With this respect, I really have to focus on one of the things about genetic predisposition, hereditary predisposition. So we see not infrequently in this situation, in this narrow situation, we see, for example, I had a patient who was in his early 50s, so it was a bit young age for the patient to develop pancreatic cancer. But we see it; it's not common. The median age, the average age is in early 70s. But we see patients who are younger. Once you see a patient who is younger, you should start to think of a possibility of a hereditary component. Now, this patient had treatment and everything, and his treatment was so successful that we suspected that he may have a genetic component because patients who have a BRCA mutation,
Right.
BRCA mutation,
Can you explain BRCA to the audience,
so
please?
sure. So the BRCA, it's a BRCA mutation. It's what called a germline mutation. A germline mutation means that every single cell in the body has that mutation. So you're born with it, in other words. It can happen either because someone passed it on, one of the parents, and you might have shared it also with your sibling, or it could be sometimes a new development for some reason it started in you, but you carry that gene mutation throughout every single cell in your body. Every single cell has it. Now, when you have that BRCA mutation, what happens is that the cell has some deficiency in correcting what we call DNA insults or DNA damage. So all of us are as we grow older, as we get exposed to a lot of things, chemicals, and whether in the environment or what we eat or what we breathe, these things really have the potential to cause what we call DNA damage. And that's the basis of when you talk about, for example, people exposed to asbestos and things like that. But here I'm not talking about asbestos. It's just saying that something from outside comes and causes some damage, some derangement in your DNA.
But what percentage of patients that carry the BRCA mutation?
Percentage of patients we diagnose with pancreatic cancer who have BRCA mutation is really in the region of, on average, 5%. So I was going to say that the BRCA gene is responsible for correcting anything that happens against the DNA. It's a DNA repair process. So in those percentage of patients individuals who have a mutation in it, they're more prone for the DNA damage to be permanent, which means leads to cancer formation.
Okay. And not specifically pancreatic cancer, because there are other cancers that
E-
carry
e-
BRCA.
Exactly right. So when I go back to the patient I mentioned to you about, he was in his early 50s. He had two daughters, and he didn't give me a family history of pancreatic cancer. He had two daughters,
Okay.
and then because he responded very well, and at the time the science was improving, and we said, and by the way, he was from Ashkenazi Jewish heritage. So people of Ashkenazi Jewish heritage have a higher frequency of carrying this gene. So my colleagues, for example, in the East Coast, it's when they talk about the average, what they see is higher than what I see in Midwest. They see more like closer to 10%. I see closer to 5%. So this patient, he didn't know if he had any family history, parents, sisters who had cancer. But then he got tested, and sure enough, he had the BRCA mutation. His two daughters got tested,
Hmm.
and one of them carried the gene, and she was young, in her 30s, and she opted to have removal of both breasts. But
Wow.
back to your point, Zahra.
Yeah.
This kind of mutation also can lead to breast cancer,
Right.
and this kind of mutation can also lead to ovarian cancer. And I've even seen some other cancers that can be predisposed by this. So this is the importance of the education. You may say, well, it only affects less than 10% of the population, but for the person who may be a carrier of the gene, it will be a life-saving thing to be aware of the consequences, and also a doctor to take care of the management of that patient.
So family history, based on what you're saying, is extremely important to understand cancers within your own family because it has an impact within the family. You mentioned other cancers that can actually also mimic pancreatic cancer. What would be another cancer in the GI area that could be a red flag on a family history other than the genetics that may help patients with symptoms?
So if I'm understanding your question correctly, is there any other cancer in the family history which is GI related that can be a red flag for pancreatic cancer? I wouldn't say so much GI related, but another cancer that in the family is important would be the prostate cancer, because the prostate cancer can also be caused by the BRCA mutation. So that's something which one has to keep in mind. And prostate cancer obviously is a very common cancer. Again, a small, narrow sector of it can be from a result of the BRCA mutations. The reason why I also mentioned the word non-specific symptoms is because people can have other, let's say, benign conditions that can also be causing abdominal symptoms. For example, someone can have an ulcer in the stomach. Someone can have chronic pancreatitis. So that's why I really want to make sure that people don't get just scared of every symptom they get as being the pain causing pancreatic cancer or caused by pancreatic cancer. But the reality is that when we come to cancer diagnosis, these are symptoms that really continue, get worse, even if they're better for a few days, but they're continuing to recur, and getting worse with time. And especially, as I said, there are things with it like losing weight, for example. Those are things that people, and more fatigue. So these are symptoms that we don't want to get to that point. We want to get earlier. So there's a bit of fine balance in not really scaring people, that thinking that everything can be cancerous, but at the same time, it's education to seek medical help,
Right.
not not sit on it.
So on that note, I think what I actually would like to know from you is, based on what you've just shared, you've highlighted some key symptoms that patients should be aware of, right? The abdominal pain, the weight loss, the jaundice. And then you talk about the BRCA mutation gene. So to be proactive for a patient, what advice would you give? Because clearly having an understanding of this is a gene that I carry, like the BRCA mutation, is important. So can patients ask upfront for the testing for BRCA? Like, how do we be proactive for patients here?
So I would like to answer your question in a bigger context, but I'm just going to start with your question about the specific question about BRCA gene. I also want to make the statement that the BRCA gene is not the only gene that causes pancreatic cancer. I used the BRCA gene as an example of some of the things which we were discussing minutes ago, but the BRCA gene is not the sole gene that can be responsible for pancreatic cancer. There are other genes that CDKN2A, for example, CHEK2, ATM. So a number of genes that can do that. Now, in patients who have a history, it's not a standard of care for patients just to walk into the PCP office and say, "Oh, I feel like I want to do a genetic test for
Right.
cancers." That wouldn't happen as such. Rarely happens, and also there's an issue of the insurance coverage, and everything goes beyond that. However, in patients who have family history of cancer, I think those are the ones who can seek such a test to be done. Now, the test we do, for example, that I sent to an outside vendor, it really looks into multiple genes. It doesn't only look for BRCA gene. You can do only BRCA gene, but the testing in someone who is a high risk for cancer because of the family history, it really is a panel of genes. So it goes beyond the BRCA gene.
Okay. And can you highlight which other genes are?
So CDKN2A, for example, also called P16. Now, that, for example, that gene also can be causing, for example, melanoma. So I'm just going to the family history. If someone says I have history of cancers, and you start to get more details, and if they say, well, I had a sister who had melanoma, now you're probably thinking maybe more into a different gene. If someone says I have a history of Lynch syndrome in the family, like members who have like colon cancer or uterine cancer, now you're thinking of a different gene, which is the DNA repair mismatch repair genes, the Lynch syndrome. So, but in my opinion, sometimes these things are missed unfortunately in this narrow, potentially curable situations, because history is not taken, or the patient doesn't give the correct history to the PCP. So there's a lot of education that goes around people at higher risk who have to be picked up early, because those are the patients where we can have a major impact on them in putting them on a curative path. Now, there is something else which is out there, and I really want to bring it up because there is some link between diabetes and pancreatic cancer.
Hmm.
But the one which really is the more linkable is what we call new onset diabetes, also summarized by NOD. New onset diabetes can be a red flag for pancreatic cancer, but the problem is a lot of people come with new onset diabetes. How do you really? You can't just scare everyone and do scans right and left and get into issues, multiple issues, all that. But that's something which has to be kept in mind. especially in like a family that is predisposed to cancer, especially in someone who has family history of cancer. So that's something, again, is an educational part in terms of the public and also primary care providers, in that there might be situations where it's new onset diabetes, but it's in a context, bigger context of there might be this might be something which I need to work harder on to try to rule out cancer in that person.
Philip, sorry.
Yeah, sorry, go
I
ahead.
was going to say we've talked a lot about the diagnosis and genetics associated with it. What's happening now when the patient comes into you for the diagnosis? They have the symptoms. What's occurring now from a treatment aspect? What's the pathway for treatment?
So as you know, John, and as you know, Zahra, the key thing in treatment planning and treatment planning first is clinical diagnosis. And I just want to go quickly over how we make the diagnosis. So the diagnosis is made when you suspect pancreatic cancer, like the person who has pain and you think that with the weight loss I'm unhappy about, or someone comes with we call it obstructive jaundice. So the reason why we call it obstructive jaundice is that the jaundice is a consequence of a tumor growing in the pancreas, and in the process of growing in the pancreas, it starts to start to press on other structures within the pancreas. And one of them is something called the bile duct. The bile duct is just a duct, a tube that brings in the bile, which is liquid, from the liver down to the lumen of the small bowel. So basically, it's a clearance tubing
Right.
duct. Now, if the tumor gets a bit bigger, it starts to press on it. It's like pressing on any flexible duct, and then the duct gets blocked. When it gets blocked, the bile is just pushed back into circulation, goes into the blood, and then the eyes turn yellow.
Yeah.
Believe it or not, those patients probably are a bit more fortunate because it means that they can be diagnosed earlier.
Right.
So we do a CAT scan. The CAT scan is our mainstay of the treatment. So a good CAT scan, or it could be MRI, but usually it's a CAT scan. And again, the CAT scan should be done in a certain, what you call, protocol. Protocol means settings. You know, when you do anything, like we do a movie or a camera, you have settings. So there's a setting that you have to do, because that setting, so it should be done in someone who knows how to do it.
Right.
And that setting is important. And I tell you why. Because in that setting, not only you're trying to find the tumor, but also you want to find the tumor, how it is in relation to the other structures around it. So the area in the pancreas is a very, very busy neighborhood. It's busier than New York or anywhere else. It's a very busy neighborhood. It means that anything which moves touches something else, right? And the most critical thing is, how much do they really touch, either kiss, hug the blood vessels? Because the surgeons cannot just remove a tumor. It's not like removing a lump from the breast where you just remove it and you don't have impact on anything vital within the breast. Here, there are vital structures around it. So why am I saying this? Because when you do the CAT scan, you identify a mass, and at the same time, you say, can I surgically remove it or not? So that's one of the things. But then again, you don't proceed with your treatment unless you get what we call a tissue diagnosis. It means that I have to get cells from this lump, put them under the microscope, and decide this is definitely pancreatic cancer. Now, there are different types of pancreatic cancer, but the vast majority are called adenocarcinoma. But it could be something called neuroendocrine tumor, which is different prognosis. Different prognosis.
Yes.
But I'm going to focus on the adenocarcinoma, which is what we say when we say pancreatic cancer. So that
I was going to ask you about PNET at one stage or other, because you've done a lot of work there as well.
I'll be happy to. Yeah, I'll be happy to, because PNET is an important topic, because people have to distinguish it from the adenocarcinoma. The prognosis is very different. But we can come back to that. So once you take the sample, taking the sample will entail usually putting a scope down the throat into the stomach, into the what called the duodenum, and then a sonar, like any other sonar you do, will direct the needle to go into the tumor and then you take a sample and you're out. Now, the CAT scan we did, we also have another purpose for it, which is another important purpose. So we look for whether the patient has what we call metastatic disease.
Mhm.
The common signs of metastases are the lymph nodes around the tumor, and also the liver and the lining of the abdomen. So we have to check for these things. Why do we do that? I mentioned to you, if the tumor is completely hugging the blood vessel, the artery
Mm.
mainly, then surgery is almost impossible. But if the patient has tumor spread to the liver, for example, God forbid, those are also not surgically resectable because there's no room for a long-term benefit for the patient by just removing the tumor in the liver.
Is
So
there,
this tumor in the pancreas, I'm sorry.
is there a size of tumor? I'm sorry, I cut you off there, but is there a size of tumor that is a threshold for surgical removal?
When we discuss these things, and thank you for bringing it up, Zahra, because I have to really answer your question in the context of tumor boards. These are pancreatic cancer. At the end of the day, is not a very common cancer. It's common enough, but not very common. Number one, and number two, because of the busy neighborhood there is some degree of surgical skill goes into doing it. It should be done by surgeons who really do a fair number of them annually. So we discuss this in the tumor board every week. Every week, tomorrow morning in our place at 8:30, we have a pancreatic cancer tumor board.
Can you explain the tumor board
So,
for the audience?
so the tumor board is we sit. It's a round table basically, and we have different specialists in it. Like, for example, myself and my team, the medical oncologists. We have the surgical oncologist, radiation oncologist, nurses, nurse practitioners, physician assistants, and we also have pathologists, and we also have radiologists. This is pretty much the core of a tumor board. We have other people like trainees. Now, in the tumor board, we will be having a look at the patient. Patient is not there, but we will be looking at the scans. There's a projection. We look at the scans. And also the pathologist will have a look at the pathology. There's a projection, how it looks like, how the cell looks like. But specifically to your point, Zahra, in that meeting, we will decide whether the patient is surgical or not. Surgical meaning, is surgery an option or is not an option?
Okay.
So, so if they have metastatic disease, it is not an option.
Mhm.
If the patient has localized disease, the major option, the major determinant is not so much the size, it's how it is really involving the other structures around it. So it could be a 2 centimeter tumor, but it's completely surrounding the artery.
Okay.
Or it could be a 4 centimeter tumor, it's further out from the artery. So the size, we don't have a threshold for the size as such. Certainly, as the tumors get bigger, there's more probability of them encroaching on the other structures. But size, only size, is not the major determinant. It's how it relates to the structures, the blood vessels especially. I
Right.
hope that answers your question.
Yes. No, it's perfect. Thank you.
The positioning is critical, right?
So the tumor board discussion is very important because that really can make a big difference on the successful management of a patient. It can make a big difference in terms of putting patients into a surgical procedure that will be curative, or sometimes, unfortunately, putting patients into a surgical procedure where the surgeon thinks, well, I can do it. They open the patient and they close, they couldn't do it. And that discussion prior to any major procedure is really vital.
Whipple's procedure, I know that that's a surgical procedure. Can you explain what the procedure is? Because many of the top people in the country have had that procedure, but it's never really explained to them.
So the Whipple procedure is a description of a surgical procedure that was devised almost a century ago, or maybe a bit more recent than that. And it really involves removing part of the pancreas. As a starter, I can tell you it's removing part of the pancreas, usually the part that we call it the head of the pancreas.
Mm.
So when we do surgical procedures on the pancreas, it's very rare to do what we call a total pancreatectomy. It's extremely rare. And a total pancreatectomy puts the patient into the risk of lifelong diabetes and all the conflicts and the difficulties of managing that, although things are much easier nowadays than years ago. But the point is that it's a procedure that removes part of the pancreas that contains the tumor. Okay? So that's the essence of it. Now, there's also other things that get removed with it. Because it's a very, very busy neighborhood, as I mentioned, the pancreas sits in a groove or a C-shaped structure, C-shaped tubular structure, tube, which is called the duodenum. So they also remove the duodenum. So for that reason, the Whipple is also called pancreaticoduodenectomy. You're removing part of the pancreas, not all of the pancreas, and the duodenum itself. And also you remove the structure, the bile duct structure that is in that part of the pancreas, and you're also removing the gallbladder. So that's a pancreatic. On top of that, you're removing some of the adjacent lymph nodes sitting next to the tumor, because these lymph nodes, you have to remove them because they can easily be structures that have received some cancer cells spilt to them from the pancreas tumor itself.
Right.
So, and sometimes they also remove a small portion of the stomach itself. So it's a very involved procedure.
Invasive. Yeah.
And when they first started doing it, unfortunately, 20-30% of the patients died of the procedure. Nowadays, it's really rare to die of a procedure like this because surgeons have improved their skills, techniques. Surgeons have now very good post-operative care provision by experienced nurses and all that. And that's one reason why you'd rather have such an operation in a place where there are the expertise, because they do it like on I wouldn't say daily basis, but they do it often enough to get a lot of experience. So nowadays, we rarely see people dying of it, and it may still be a life-threatening thing. But what really comes out of this discussion is also that patients who are older or frail, they may not be able to undergo this procedure. So that's something that you have to keep in mind.
So just to go along the lines what John was saying initially. So you walked us through like the initial symptoms, kind of the diagnostics. And so before we move straight on to like immediate treatments, as to what you were saying, if the tumor is large enough, or if it's not based on size only, but the structures that it's impeding on, is there an opportunity for giving like chemotherapy or an intervention up front to reduce the size and then surgically remove it? Because that's considered neoadjuvant and that's given in a lot of other cancers. Is that available?
Yeah. So that's an excellent question, because generally in oncology, in a lot of diseases, as you may know, we have moved into giving chemotherapy upfront before surgery. There are a number of reasons for that, and I'm going to put it in the context of pancreatic cancer, obviously. Number one, when you give chemotherapy upfront, then you increase the chances of a successful surgical removal, because you're reducing the tumor volume and maybe even sometimes detaching it away from the blood vessels that we don't like. So really, one important aspect of this is that you want your surgery done in a way that no cell is left behind. We call it clear margins.
Mhm.
The other thing, we call it R0 resection, which means that the surgeon removed everything, and there is no way that he or she left any cells behind. And this requires, obviously, again, emphasis on the surgical expertise.
Right.
Now, if you do chemotherapy up front, you increase the chances of what we call an R0 resection.
Is that chemo with
Well,
immunotherapy?
I'll come to that.
Okay.
If you give me a second. Well, let me answer the question. No, it's chemotherapy. Immunotherapy hasn't developed a role in this situation. It's
Mhm.
chemotherapy. But again, John, you know, with your experience, and I'm sure Zahra knows, chemotherapy has side effects. And we try to give them aggressive treatment because this is a aggressive tumor, right?
Right. Right.
Now, think of it this way. When I describe to you the surgical procedure, you say, oh, wow, that's a lot of stuff to be removed, right? What it really means is that after that stuff is removed, even in a younger, healthy person, recovering from operation can take a while, right? And sometimes people take a long while to recover. And sometimes the rare patient might never recover well. So where am I really going with this? With pancreas cancer, even with pancreatic, we also know that there's a significant risk for the cancer to come back. Now, why is it coming back? Because although we think that everything has been removed and the scans are clear, there are some cells that are floating in the system. So we need the chemotherapy to be given to the patient. We used to traditionally give chemotherapy after surgery. But the problem is, if you give it after surgery, only half of the patients can get meaningful chemotherapy because they're in the recovery phase. So think of it logically. Why not I give this whole chemotherapy before surgery?
Right.
The patient is fitter to get the treatment. So back to the point Zahra raised, yes, we give chemotherapy before. Increasingly, we do that. In fact, there is a big swing to that to reduce the size of the tumor, but also to treat the we call it micrometastatic disease, those cells that are hanging around at a time when the patient is best fit for it. Because we know chemotherapy adds to improvement in the survival on top of the surgery. And if we do it before surgery, then we're guaranteeing more of the chemotherapy to be given and hopefully better tolerance from the quality of life point of view, but also maybe effectiveness.
That's several different types. Is that a combination chemo that you're giving, or is it monotherapy?
Always combination chemotherapy.
So what chemotherapies are the most commonly used in this stage?
So it started off with single agent gemcitabine, but that was overtaken quickly by combination of gemcitabine and capecitabine, and then further by a triple combination, 3 drugs. We call it FOLFIRINOX, which has 5-fluorouracil, irinotecan, and oxaliplatin. And not every patient can get the triplet, or we call it triplet. But again, if you give it before surgery, you stand a better chance of giving it to the patient.
So now so patient has received upfront chemo, any of those 3 that you just mentioned, they received the surgery. What now happens? What's the next stage for the patient?
So after the patient gets the surgery, usually we give the chemotherapy like 4 months, around 4 months, and then maybe a month or so recovery, then surgery. And after that, the case comes back to the tumor board. So again, the importance of the tumor board. Now we look into was it R1 or R0 resection? Was there any can the pathologist say there was any effect of the treatment on the cells? Was some cells dying or not? And how many lymph nodes had it? At that point in time, we make the decision becomes usually giving some additional 2 months of treatment with the same treatment. Or it could be a patient cannot take more treatment. If the surgeon says the patient is too weak, then we stop at the 4 months we give before surgery. Or, for example, we say maybe they need radiation because there are some cells left behind. We need to give radiation. So it becomes a discussion. After the patient is done with either more chemotherapy or radiation, then they go into what we call active surveillance. And active surveillance will be doing scans every 3 to 4 months, blood tests, tumor markers, and all that. So that's really how the journey goes into those patients.
I read an article just published on ultrasound being used more and more for this follow-up.
Actually, we don't use ultrasound at all because either a CAT scan or an MRI is still a much more sensitive and informative test. Now, what would be something people sometimes tend to do is something called circulating tumor-free DNA. That's not really a standard of care. You can do it, but it's not. I would not do it routinely in my patients.
Okay.
You mentioned as part of active surveillance, it's either the CT scan or the MRI, and then there's also tumor markers or blood markers. So can you highlight some specific markers that are important for patients to be aware of?
So the key one is called CA19-9. CA19-9, that would be the one which we use exclusively in this situation. Keeping in mind there will be a proportion of patients, 10% or less, who genetically will never be able to produce the CA19-9. So that CA19-9 monitoring will not be beneficial to them. But CA99, and also we use CEA, but CA99 is really the best one to use. As I mentioned, ctDNA will be another way of doing testing in the blood, but it's still not standard.
Data now is coming out that just recently with cholangiocarcinoma, there's fusion inhibitors. What new pharmaceuticals are coming out to actually help with this disease? Because you mentioned that the survival rate's gone from 4 to 10%.
To be accurate, if you look at the recent publications, they call the survival rate would be 13%, but that also includes in it the pancreatic neuroendocrine tumors. So that's why I put it 10%, but just to 8 to 10%, let's say. So doubling at least. So your question is really very valid because John and Zahra, if you remember, let's say 3 decades ago, mid-90s, we only had chemotherapy, and we treated everybody with chemotherapy, including lung cancer, colon cancer, and pancreatic cancer, which, as I said, we barely had one drug. Over the last 3 decades, the explosion of the knowledge in molecular biology led to targeted therapies, right?
Right.
And some of the diseases like non-small cell lung cancer some of the patients now survive many years because of targeted therapy. For the reason that was brought up by John, we have now target treatments. Even biliary cancer has target therapies. Pancreatic cancer didn't have really much luck in that.
Okay.
So the increase in the survival in 5 years is more like early detection, better treatments in general, surgical, multimodality treatment. I would put it more on that and some chemotherapy, and I would put very little, if any, on the targeted therapies.
Right.
The only targeted therapy that started being of some use a few years ago is targeting PARP with olaparib was FDA approved. So that's the only one truly. And then since then, there are target therapies approved that we can use in pancreatic cancer, but these mutations happen in frequencies that are exceedingly low, like NRG1 mutation. There's a target approved by FDA, but that's only in 1 to 2% of the patients.
Okay.
Like the microsatellite instability high, for example, it's only 1 to 2% of the patients. I mean, if you really want to add, the most you can say is that 8 to 10% of the patients may end up with targeted therapy. However, the big revolution now everyone should be aware of, and so these are the good news now coming to, is that 90% of the patients have something called KRAS mutation. For a long time, the KRAS mutation was really you can't do anything about it. People tried different things. Now there's an explosion of pharmaceutical companies, the research that is really working on the KRAS itself. And in fact, some of the drugs have already been shown to be working very well. For example, Revolution Medicine has a drug. In fact, there are multiple drugs, even within one company. So that's really is going to be in the next 5 years a game changer.
Can you further elaborate on the KRAS mutation? So if a patient is wild type or if they're a mutant or like KRAS mutant, not a mutant patient, KRAS mutant, then there's specific targeted treatments. And what are the survivals? How do patients obtain this? What does the data look like? And is it outside the clinical trial?
So let me just go back a step and say, what is KRAS? Because that's your question. And I would like my audience certainly be familiar with. In cancer biology, how cancers develop and progress, we think it's a genetic disease. You guys agree with me? It's a genetic disease.
Definitely.
Somehow it's a genetic disease. We're not talking about necessarily inherited genes, but genes that get damaged as the process of aging and other things, and then a gene flips and becomes cancerous gene. So there are 2 types of genes. One, we call it oncogene. It used to be called proto-oncogene, still called proto-oncogene. Oncogene meaning that is a gene that when it flips becomes mutated, it becomes a what you call a driver gene. That gene becomes uncontrolled. It's continuously sending signals to the cell saying divide, spread, and makes the cell very survivable. Like it's like having a plant in the desert and now it can flourish and spread and all that, whereas a normal plant cannot. You understand that?
Yes.
And also there are a set of genes that are called tumor suppressor genes. These are the genes that put a brake on the tumor itself, on the cell to become uncontrollable. So there are oncogenes and tumor suppressor genes. Now, both of them are mutated in pancreatic cancer. It can be, but both kind of genes can be mutated. Not exactly, yeah, both of them can be. And it starts very early in the cell development, which takes me back to the thing about when I see a patient in the clinic and they have cancer, and they say, well, I had a scan, everything done last 6 months ago, 1 year ago, I was fine. I say, your cancer started 10, 15 years ago. You just don't see it. And this is what's happening. The gene mutations that are happening in normal cells of the pancreas driving it to be cancerous. So KRAS is an oncogene. It's a driver gene. It's a dominant gene that pushes the cell to really divide, spread, and evade any control mechanism. So it protects the cell. So if you can, and you know that the genes exert their effect by the proteins so each gene, every gene you have in the body, the DNA, it produces a protein which is specific to that gene. So it gets translated into forming a protein, and that protein does all these bad functions.
Right. Yeah.
So the question is, how can we silence this protein?
Right.
Okay, so that's where the pharmaceutical industry now went into the extra step, not extra step, I mean, that was an evolution of research in terms of finding small drugs, small molecules that can go and attack or get, they bind into that protein, and in certain corners of the protein that will paralyze the protein from working, basically. That's the best way I can, or neutralize the protein, or neutralize the effect of the KRAS bad effect on the cell. So these are drugs that currently are in development in different ways of trying to attack the protein and bound to it. And that's another hour of discussion, scientific discussion. But the bottom line is that these drugs now are being tested actively. There are multiple clinical trials in the country, which means that a patient with pancreatic cancer today can probably get enrolled in one of these clinical trials.
You're involved in SWOG, talking
Yes.
about clinical trials. You're the head of the GI
Committee.
committee. So KRAS is in a lot of cancers.
Yes.
Is there different KRASs? Because you've got KRAS inhibitors already, but not everyone, maybe every KRAS is similar or different.
Correct. So KRAS mutation is not only in pancreatic cancer. It just happens that in pancreatic cancer, 90% of the patients have KRAS mutation.
Wow,
But
90%.
But in colon cancer, for example, it's like 40, 45%.
Yeah. Right.
In biliary bile duct cancer, for example, it's 20% or 30%. So it depends. In lung cancer, there's a fair number of people have KRAS mutations. So it's present in different cancers. The impact of treatment may not be equally the same in different cancers. And again, that's another discussion, and I can go somewhat into it. When we say KRAS mutation, there are different allelic mutations. So there is for example, there's just an example to illustrate the point. In pancreatic cancer, the KRAS mutation can be something called G12C,
Right.
which there are drugs for it, by the way, but that's only 1 to 2%. It could be G12D, which is the bulk of the mutations, could be G12V or G12R.
Okay.
In colon cancer, the distribution will be a bit different. So something which is interesting is that these drugs that are being developed, John, some of them are specific to one allele kind of thing, and some of them we call them pan-KRAS. They do all whatever mutation there is, it may affect it. So so it's really interesting that being developed. But we always have to sit back and say, is it truly targeting the KRAS? The answer is yes. Is it truly targeting only cancer cell? We always have the issue of, but there is non-specific also on the normal cells. Nothing comes free. So we have to keep that kind of thought in mind. And that's been what we're dealing with target therapy over the last 20 years anyway. No one is saying you give the treatment, it targets the cancer only, and nothing happens with the normal cells.
Dr. Philip, with regards to metastatic pancreatic cancer, because we've spoken about, obtaining chemotherapy or some modality up front, you take the patient for surgery, and then the patient's followed for active surveillance. What about the metastatic patient?
So metastatic patients, it's pretty much only what you call systemic drug therapy. There's no surgery. We use radiation therapy sparingly if there is some painful area, but it's chemotherapy. And in metastatic disease is really now where the KRAS is being tested. I mean, that's where the KRAS drugs now are being tested in the metastatic disease. And that's the way it works. You test in the metastatic disease, it works, and you take it now to add it to the neoadjuvant chemotherapy, for example, we talked about, or adding or giving it after surgery, maybe as a maintenance treatment. So for metastatic disease, we have only two cocktails we use. One is gemcitabine, nab-paclitaxel, and the other one is the FOLFIRINOX I mentioned to you. And these are the only ones we use. In metastatic disease, quality of life also becomes very important, and patients have to be evaluated whether they can tolerate such treatment. In metastatic disease, it also requires experience in dose allocation and titration as the patient goes along, because quality of life becomes much more important in those patients. When you have the resectable patients where you can do surgery, you can accept more side effects because the yield you're looking for is cure if you can get that. In metastatic disease, cure is not possible. Therefore, you have to be very careful in how much you push your treatment. And that should be it doesn't mean you don't treat patients. You just have to be having an oncologist who can give you the treatment in a way that they can tailor to your situation, your health, your needs, etc.
Philip, it's been a fantastic talk, and obviously we're going to have you back. There's just no way about that. But usually how we finish is we'd like you to summarize this talk into 3 or 4 key points for the listeners so that they get the take-home messages about early diagnosis, early treatment, and genomics associated with this disease.
Well, thank you very much for having me. I truly enjoyed it. Excellent questions, by the way. Excellent questions. So
you trained us, so train me.
So the key point, the major key point here is that, John and Zahra, that things are, for the first time, looking much better than they used to for pancreatic cancer. And there are a number of reasons for that. There is certainly improvement in the 5-year survival. But to me, the most important thing is that, unlike many years ago when I used to go to meetings and things, people didn't want to discuss pancreatic cancer. Yeah. Now you have so many young investigators that are jumping into pancreatic cancer because the door is now open for them to really go into it. In the older days, it was like, who wants to really invest their time and effort in a disease that, let's do breast, let's do prostate. Now things have changed. So that's really is driving the same thing with the pharmaceutical industry. Now they want to invest in pancreatic cancer. In the older days, they said, well, you know what, we did this drug, it didn't work, we did that drug. Now it's different. The key thing which really drove this was public awareness, advocacy. And I have to I'm part of PANCAN, Pancreatic Action Network, and PANCAN has done a lot. And I've been to Congress for lobbying, and we've done these things. People understood the need to really do more in this disease. What really made a difference also is the advances in the molecular biology of pancreatic cancer, understanding and putting that into those new treatments. Certainly, patients have to be diagnosed earlier. We always that's a given in cancer. It applies to all cancers, even cancers that patients do much better. We need to diagnose it early. And patients have to be aware of some of the symptoms pain that doesn't go away, pain that gets worse, weight loss with it, yellowness in the eyes that we talked about, the jaundice. And they have to communicate very quickly with their primary care provider. Individuals who have an unusual family situation in terms of number of cancers, forget about it being pancreatic cancer in the family or not. Unusual combination of cancers, especially in first-degree relatives, should always talk to their PCPs for the need for genetic evaluation, referral to a genetic clinic, etc. So that's really very important. Patients who have advanced disease have to always consider being on clinical trials because I only mentioned KRAS. There are other treatments that are really out there that are being tested new. So all in all, we need patients or individuals in the community to be aware of all these developments in a disease that we're still considered as a very tough disease to deal with.
Well, Philip, thank you very, very much.
Thank you.
And on behalf of our listeners, we can't thank you enough, A, for all the research, education that you're doing, B, for all the patients that you've treated throughout your years, and your passion for this disease is just unbelievable. And I completely admire everything that you're doing at your institutions that you're working on, and also SWOG. We didn't get a chance to talk about SWOG, but the Southwestern Oncology Group is a major force in clinical trials that you're heading up in that area for the GI neuroendocrine disorders. So thank you very, very much.
Thank you. Thanks, Dr. Philip. And as John said earlier, we need to call you back because there's lots of discussions around PNET that we would like to pick your brain on as well. So thank you.
Yeah, I would like to do PNET because I have the largest practice in Michigan. So yeah.
That'd be wonderful. John's like, yes.
But then again, what you're doing is I don't know how to describe it. I mean, the ability to project this to the community as an education and also inspiring people and others to really be part of educational aspects. I mean, this is really unbelievably rewarding, I have to say. And all I need is when you come to ASCO, hopefully both of you come, I need you to buy me a coffee.
That's on John because my Canadian dollar is so weak.
I'll definitely buy you a coffee at ASCO. There you go.
Thank
you, Philip.
Thank you. Bye-bye.
Okay,
Have a good day.
Ciao.
Bye.
Ciao.
Ciao. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.